What should we do when a tooth root or an implant gets displaced into the maxillary sinus? Today on the open reduction. Welcome to the Open Reduction, your channel everything oral and maxillofacial surgery. I'm Dr. Tom Bolten, and today we're going to be talking about a complication, a tooth root being displaced into the maxillary sinus. Maxillary molars can be a nightmare to remove. The roots are often divergent, the tuberosity is weak, and the maxillary sinus is literally hanging over the work at hand. I'll never forget the first time a root tip did a disappearing act on me. I was trying to tease out the mesial-buccal root of tooth number 3 when all of a sudden I saw a black void. Cue the sweat and spiking heart rate. A displaced tooth root, implant, or foreign body into the maxillary sinus can cause a chronic oral antral communication and a fistula, nasal discharge, sinusitis, and chronic headaches. The maxillary sinus has a lot of variability in size and area. The average size is 12 to 14 milliliters with a range of 9 to 20 milliliters. Men typically have larger sinus volumes. If patients lose teeth in the posterior maxilla, the sinus is likely to pneumatize or increase in size and drop inferiorly. The sinus is lined with a thin membrane called the Schneiderian membrane. The only exit of the sinus is the ostium, which is a small hole located posteriorly and medially within the sinus near the roof. It typically measures 2 to 4 millimeters in diameter. This is a good thing because it means that most things that end up in the sinus cavity stay there and are retrievable. The maxillary molars are at the highest risk of a complication associated with the sinus, but maxillary second premolars can be close to the floor of the sinus as well. Preoperative radiographs at appropriate angles are very important to determine how close the roots are. PAs are helpful, but they can be misleading if the angle is poor. This is why I love Panorexes and cone beam CTs. These image modalities will accurately display how close the root truly is to the sinus floor and are great for patient education and for informed consent. Here's the tale of my first root into the maxillary sinus. I was gingerly trying to tease out the mesial-buccal root of tooth number 3. I had about half the root out and the palatal and distal buccal roots came out no problem. The root tip in the mesial-buccal space was holding strong until suddenly it disappeared into a black void. I immediately grabbed the suction and attempted to retrieve the root by placing it over the hole. When this proved unsuccessful, I recalibrated and started to follow the protocol. First, it's critical to confirm that the root is actually in the maxillary sinus. It's not hard to push roots through a thin buccal plate into the subperiosteal region adjacent to the alveolar bone. Maxillary second bicuspids and first and second molars are most likely to fall into the sinus, but maxillary third molars can potentially fall into the infratemporal space, which is a completely separate problem that I address in different videos. Check out the channel. Cone beam CTs are the ideal imaging modality and will accurately display where the root is sitting. A Panorex is a distant second, but at least it will help. A periapical film can be helpful to confirm whether or not the root is still in the extraction socket, but if the root did fall into the sinus, a PA most likely is not going to spot it. The cone beam CT confirmed that the root was in the maxillary sinus, so the next step was retrieving it. Fortunately, we practitioners have a great ally in this situation: gravity. I sat the patient up in the chair and opened up the site slightly with a round burr and attempted to visualize the root. When the patient is in the supine position, the root will naturally fall into the posterior portion of the sinus. By sitting the patient up, the root will fall back towards the opening thanks to gravity, which makes retrieval through the initial perforation more likely. Next, I took syringes and irrigated the site thoroughly. The idea here is to flush the sinus and let the water carry the root down to the opening. This maneuver has saved me several times. Unfortunately, this wasn't one of them. If irrigation fails, the next move is mechanical retrieval with a 4x4 gauze. I unfolded a 4x4 gauze until it could not be unfolded any further. Then I packed the sinus as much as possible with leaving just a thin tail to grab onto. Then I slowly teased the gauze out and try to visualize the root. The intent with this maneuver is to trap the root almost like a net in the gauze and then gradually drag it out to the opening. If the root doesn't become entangled in the gauze, at least it will hopefully follow the gauze out and we'll be able to visualize it once the gauze is gone. Thankfully, this move worked. I took a sigh of relief, irrigated, placed the collar plug, and then advanced a small mucoperiosteal flap to get a nice closure. I placed the patient on sinus precautions and then saw him back 2 weeks later to ensure appropriate healing. Let's say the gauze maneuver didn't work and there was no way I could retrieve this root from the extraction socket. In this case, the next and final step in the protocol is a lateral window into the sinus, also known as the Caldwell-Luck approach. This is a great way to gain access and visualization into the maxillary sinus and retrieve foreign bodies. If you want to see how the Caldwell-Luck approach is done, please check out my channel where I've got videos on how to do it. Bottom line, if you remove enough maxillary teeth, eventually you're going to have this complication. It's just a basic fact of human anatomy. Fortunately, this is a very manageable problem, and the chances of a post-operative morbidity are low if the root is retrieved and the site is closed appropriately. Even though this example is about a displaced root, the same protocol also applies for a displaced implant or other foreign body into the maxillary sinus. Thanks so much for watching. Please click that like button, subscribe, and reach out to me if you have any questions or if there's any other topics you'd like me to address. I'm Dr. Tom Bolten. Catch you next time on the Open Reduction.